Myocardial infarction is also known as a heart attack. It typically occurs when there is a rupture in the atherosclerotic plaque in the coronary artery, leading to the formation of a blood clot in the blood vessel. This is known as thrombosis. So the blood clot or the thrombus blocks the flow of blood to certain areas of the heart, causing myocardial ischemia. If blood flow is not restored in time, the cardiac muscles will die. So one major aim when treating myocardial infarction is to improve coronary blood flow. This can be achieved through a few methods: surgery, for example, PCI and CABG, medications like clot-dissolving medications which can open up the blocked arteries, and these are called thrombolytics, antiplatelet and anticoagulant drugs which will help to prevent new blood clots from forming, and vasodilators such as nitrates which can help to open up the blood vessels to increase the blood flow to the heart. Another important aim is to decrease the oxygen demand of the heart. So beta blockers help to reduce heart rate and contractility, and ACE inhibitors help to reduce peripheral vascular resistance. It has been shown that the use of beta blockers and ACE inhibitors helps to improve patient survival after a myocardial infarction. So these are the drug classes used in myocardial infarction. Antiplatelet drugs and anticoagulants prevent further blood clots from forming. Thrombolytics will help to dissolve existing blood clots. Nitrates and beta blockers have already been covered in the angina section, and beta blockers and ACE inhibitors have also been previously covered in the hypertension section. So in this section, we will be focusing on antiplatelets, anticoagulants, and thrombolytics. Before we dive into the medications, let's first do a revision on how blood clots. When there is a rupture of the atherosclerotic plaque, damage to the blood vessel walls occur. Three things occur to help the blood to clot. First, a brief spasm of vasoconstriction occurs. The blood vessel walls constrict, which slows blood flow to the injured area while the clot forms. Next is the formation of a platelet plaque, where platelets will aggregate to the injury site and stick together to form a plaque. Now, how does the platelet plaque form? When blood vessels are damaged, collagen fibers are exposed. The platelets, which are circulating in the blood, would then stick to the collagen and become activated. These activated platelets would then release chemicals such as ADP and thromboxane A2 that would cause the aggregation of more platelets to the site of injury. A platelet plaque is then formed at the damaged site. Next, there is also a process of clot formation where a fibrin mesh is formed. In clot formation, a sequence of clotting factors are activated. They interact in a complicated series of reactions where one factor activates another, which activates another, and ultimately generates thrombin. So if we look at this flowchart, here is thrombin. Thrombin converts fibrinogen, which is a soluble plasma protein, into fibrin, which polymerizes and forms a fibrin polymer mesh. The fibrin mesh traps platelets and blood cells, stabilizing the clot. Let's take a closer look at the series of events. Earlier, we saw that thrombin converts the soluble fibrinogen to fibrin, which forms the clot. But how is thrombin itself activated? Thrombin is formed from its inactive form, prothrombin. When damage occurs to tissues, the extrinsic pathway is activated. When blood vessels are damaged, the intrinsic pathway is activated. We will not go into the details of all the clotting factors involved in these two pathways. The clotting factors are numbered 1 to 13 using Roman numerals. Both the intrinsic and extrinsic pathways lead to the activation of factor 10, which converts prothrombin to thrombin. The blood must stop clotting at some point. So, what stops the clotting? The clotting factors, which are plasma proteins, are carried away by the bloodstream. The fibrin that is formed exerts a negative feedback inhibition on thrombin. Basically, the fibrin stops more thrombin from being formed. The clot also secretes tissue plasminogen activator, which is known as TPA, which converts plasminogen to plasmin. And plasmin is an enzyme that dissolves the blood clots. Now that we know how blood clots, let's look at our first drug class. Antiplatelet drugs are drugs that inhibit the aggregation of platelets. There are three subclasses of antiplatelet drugs: aspirin, thienopyridines, and glycoprotein 2B3A inhibitors. First, let's look at aspirin. You have probably already heard of aspirin's use as a painkiller and anti-inflammatory drug. Let's see how it works. Aspirin irreversibly inhibits the cyclooxygenase enzyme. This results in decreased synthesis of prostaglandins and thromboxane A2. The decrease in prostaglandins is responsible for its anti-inflammatory effect, and the decrease in thromboxane A2 will help to decrease platelet aggregation. So the mechanism of action for aspirin's antiplatelet action is that it inhibits the formation of thromboxane A2 that causes platelets to aggregate. Aspirin has been shown to reduce death after a myocardial infarction. It is first given at a higher dose of around 160 to 325 mg as soon as the heart attack is recognized. And then it is also continued on a daily basis indefinitely after the heart attack at a lower dose of 100 mg daily. The only reason for not using aspirin is a history of intolerance or allergy to aspirin. Besides its use in the treatment of myocardial infarction, aspirin is also used in the treatment of ischemic stroke where a blood clot forms in the brain. Another type of antiplatelets is thienopyridines, which are ADP receptor antagonists. During the formation of the platelet plug, activated platelets release chemicals such as ADP, which encourage aggregation. So these drugs inhibit the ADP receptor on the surface of platelets and thus prevent platelet aggregation. Thienopyridines are more potent antiplatelet agents compared to aspirin, but they are also often given together with aspirin after a heart attack, and they can also be used in patients who cannot tolerate or who are allergic to aspirin. Examples of these drugs are clopidogrel, brand name Plavix, and ticlopidine, brand name Ticlid. With ticlopidine, there is also a rare but serious side effect, which it can cause low platelet and/or white blood cell counts. Our last class of antiplatelets is the glycoprotein 2B3A inhibitors. Platelet aggregation is mediated by this glycoprotein 2B3A receptor. So these drugs inhibit the glycoprotein receptor on the platelet, thus preventing aggregation of the platelets. Glycoprotein 2B3A inhibitors are very expensive and must be given intravenously. They are usually given together with aspirin and heparin, and they have a very quick onset of action within minutes. The role of glycoprotein 2B3A inhibitors in the treatment of myocardial infarction is actually quite limited. They are used in patients undergoing percutaneous coronary intervention or PCI to prevent the formation of blood clots during and immediately after the procedure. Examples of such drugs are abscesumab and aptifibatide. Abscesumab is a monoclonal antibody, while aptifibatide is a small molecule. Both of them are available as intravenous agents. As with all other antiplatelets, these drugs can cause bleeding. A rare but serious side effect is thrombocytopenia, which is low platelet counts. Let's move on to the next class of drugs, which is anticoagulants. Anticoagulants prevent blood clots by inhibiting one or more of the clotting factors in this whole clotting cascade. This prevents fibrin from being formed and thus prevents the formation of another blood clot. There are many different anticoagulants available as injectable or oral medications. The oral anticoagulants were represented by one drug, warfarin, for over 50 years. Now, the newer direct-acting oral anticoagulants are also available. Heparins are parenteral, which means injectable medications. Let's first look at warfarin, which is the oldest oral anticoagulant. The synthesis of clotting factors 2, 7, 9, and 10 in the liver requires vitamin K. Warfarin prevents the activation of vitamin K and therefore prevents the synthesis of these clotting factors. Warfarin has a narrow therapeutic index, which means that small fluctuations can lead to either therapeutic failure or serious bleeding adverse events. In Singapore, the brand Maravan is commonly used. The tablets are available in different colors for different strengths. This helps the patient to differentiate and distinguish the different tablet strengths. Because of the narrow therapeutic index, it is important that patients do not switch the warfarin brand without supervision. There are many things to take note of with warfarin. It has a narrow therapeutic index, and the dose needs to be adjusted very carefully. Regular monitoring of INR is required. INR stands for International Normalized Ratio and is a measure of the time taken for your blood to clot. It has a slow onset of action. There are circulating clotting factors in the blood, so it takes a few days for the clotting factors to be depleted. So if immediate anticoagulation is required, the patient may need to be on bridging therapy such as heparins for a few days while waiting for the warfarin to take effect. It also has a slow offset of action. After stopping warfarin, it takes time for the liver to produce sufficient amounts of the vitamin K dependent clotting factors. This means that when a patient on warfarin needs to go for surgery, some advanced planning is required to stop warfarin a few days before the surgery to prevent bleeding complications. Warfarin is extensively bound to plasma proteins and metabolized by CYP450 enzymes. So warfarin has many drug interactions. It can interact with plasma protein bound drugs, drugs that inhibit CYP450, drugs that alter coagulation, for example, aspirin and NSAIDs, and foods that are rich in vitamin K. Foods that are rich in vitamin K can decrease the effect of warfarin, so patients on warfarin cannot make sudden changes in their diet. Warfarin and other anticoagulants are used for myocardial infarction and also for other thrombotic conditions such as deep vein thrombosis, where a blood clot forms in the veins, and pulmonary embolism, where a blood clot travels to the blood vessels in the lungs. Naturally, the main side effect of warfarin is excessive bleeding. Warfarin is also contraindicated in pregnancy and is labeled pregnancy category X. The FDA pregnancy categories A, B, C, D, and X classify the potential risk of medications to a fetus. Category A indicates no risk to the fetus in humans. Categories B, C, and D indicates increasing risk. And category X indicates a high risk and the use of such drugs is contraindicated. In warfarin overdose, the treatment would be to give vitamin K injection and fresh frozen plasma which contains clotting factors or prothrombin complex concentrate. Because of all these difficulties mentioned earlier with warfarin, there is a need for alternative anticoagulants. Direct oral anticoagulants are the new generation of oral anticoagulants. They act on specific clotting factors in the clotting cascade. Dabigatran, brand name Pradaxa, is a direct thrombin inhibitor which blocks the action of thrombin, preventing it from converting fibrinogen to fibrin and therefore inhibiting clot formation. There are also several direct factor 10A inhibitors. The A here stands for activated. So factor 10 is the inactive form and factor 10A is the active form of factor 10. Factor 10A inhibitors such as apixaban, rivaroxaban, and edoxaban bind to factor 10A and prevent the coagulation cascade from progressing. Similar to warfarin, direct oral anticoagulants are used after myocardial infarction, ischemic stroke, and other conditions related to thrombosis. Direct oral anticoagulants are more expensive than warfarin, but they offer several advantages. They have a rapid onset of action, hence there is no need for bridging therapy with heparins at the start of treatment. They have a predictable anticoagulant effect, hence there is no need for INR monitoring. Each drug targets a specific coagulation enzyme, hence there is low risk of off-target adverse effects. These drugs also have low potential for food interactions, therefore there are no dietary precautions unlike with warfarin. And there are also fewer drug interactions, which then result in fewer drug restrictions while the patients are on this therapy. Now let's look at heparin, which is actually the oldest anticoagulant used in clinical medicine. Heparin is a naturally occurring polysaccharide and it is present in mast cells, that is a type of white blood cell that plays a crucial role in the immune system and in allergic reactions. Antithrombin 3 is a crucial protein in the blood that regulates blood clotting. It acts as a natural anticoagulant. Heparin binds to antithrombin 3 and enhances its activity, subsequently inhibiting thrombin and factor 10A. Unfractionated heparin is obtained from animal tissue and contains heparins of different chain lengths which have different biological effects. Hence, its effect is broad and unpredictable. It can be given through intravenous infusion or subcutaneous injection. Low molecular weight heparins are prepared by cleaving the unfractionated heparins into fragments of lower molecular weights. Its effects are more predictable, therefore low molecular weight heparins are much more commonly used. Examples are enoxaparin, dalteparin, and fexaparin. Heparins are always the preferred drug when an anticoagulant must be given to a pregnant woman. Due to its large size, heparins do not cross the placenta and therefore cannot affect the developing fetus. Heparins have some side effects, and this includes, of course, bleeding, as well as skin necrosis at the injection site. This image here shows heparin-induced skin necrosis. Since heparins may be obtained from bovine, which is cow, and porcine, which is pig, components, they may trigger hypersensitivity reactions in some people. In the event of heparin overdose, protamine is given. Protamine binds to heparin and interferes with its binding to antithrombin 3, thus reversing its anticoagulant effects. Finally, let's look at thrombolytic drugs. These are the only drugs that can dissolve the blood clots. In comparison, the antiplatelets and anticoagulants can only prevent further blood clot from forming. Thrombolytic drugs convert plasminogen to plasmin. Plasmin is an enzyme that dissolves blood clots by breaking down fibrin. Hence, thrombolytic drugs are also known as plasminogen activators and fibrinolytic drugs. Besides myocardial infarction, thrombolytics may also be used for other disorders where clots form, for example, deep vein thrombosis and pulmonary embolism. Thrombolytic drugs can reduce deaths by 60% if they are used within 3 hours of an acute myocardial infarction. The first generation thrombolytics are streptokinase, which is produced by streptococci bacteria, and urokinase, which is formed by the kidneys and found in the urine. These drugs are non-fibrin-specific plasminogen activators, meaning they do not require the presence of fibrin to start converting plasminogen to plasmin. Hence, there is a risk that they may activate the formation of plasmin in other parts of the body besides the clot and cause bleeding complications. Being a bacterial protein, streptokinase is highly antigenic and it may cause allergic reactions in some people. The second generation thrombolytics are the tissue plasminogen activators. Alteplase is a recombinant form of the naturally occurring human TPA and is also known as rTPA. The R here stands for recombinant. Retaplase is a genetically engineered smaller derivative of the recombinant TPA, and it has increased potency and is faster acting compared to rTPA. These drugs activate plasminogen on fibrin clots, so their effect is more localized to the clot compared to the first generation thrombolytics. After completing this section, you should be able to list the various classes of antiplatelets, anticoagulants, and thrombolytic drugs. You need to know how to state the mechanism of action for each drug class, identify the common drugs in each class, and state their common side effects and drug interactions.